Dr. Sukumar?
Sir, good evening, sir.
Good evening. Ready?
Sir. Yes, sir. Yes, sir.
Right. Wait till 25 members come.
Yes, sir. Yes.
Then see whether Dr. Ravi Ramadwar.
Sir has come, sir, actually.
Huh?
Sir is there in the participants list. Maybe.
Yeah. You ask him to unmute.
Yeah.
Hello, good evening.
Good evening, Dr. Ravi.
How are you? Everything okay?
Yeah. Fine, sir. Fine.
Yeah. Good to see you all.
Yes, sir. Good evening, sir.
Good evening, Ravi.
Good evening. Yeah, nice to be back with a friend from Hyderabad.
Nice to see you.
You're still in the hospital.
So now you are operating in what is that SSL hospital, sir?
No, there are multiple hospitals. I operate in 6 different hospitals in the city.
Okay.
So that SRCC
what is your
Children's
main
Hospital
work is in which hospital?
No, it's distributed because every setup has got different advantages, disadvantages. So people choose the hospital as per their insurance policies, as per their convenience, location from home. So number of factors are there. So plus the COVID policies.
Okay.
So all those factors affect. So that's why the option is there for patient to pick and choose whichever hospital they want.
Okay.
And we have the backup for almost everything in most of the hospitals. So there's no issue.
Ravi, Dr. Abraham Cherian and Dr. Anupam Lal have joined.
Oh, wonderful. Great to see you, Abraham. Hey, how are you? Everything okay in London?
Yeah.
You guys are behaving yourselves?
Yeah, we're trying.
Yeah, you're trying to get the third wave very fast, I believe. So, so are we.
Mid-August.
Abraham, good evening. Thanks for joining. Thank you so much.
No, pleasure.
It's a pleasure.
Good evening, sir. I am Dr. Narendra Kumar.
Hi. I think we have met.
Yeah, in the conference.
When I came to Hyderabad.
Yeah, pediatric urology conference we met. Sir.
That's correct.
Welcome, sir.
Anupam is also here. Anupam?
Hi.
Hey, hi, Anupam.
How are you guys? Nice to see
you.
Hi.
Hello, sir.
Everything okay at your home? And
everything fine. Yeah.
Good.
Yeah. Surviving.
Anupam was my senior in AIMS and we used to do duties together.
Yes, we were.
So that continues, is it? He's still on his duty.
I am, yes. How are you doing, Ravi?
I'm good.
Excellent.
Shall we start, Chandrasekharam?
Yeah, sure, sir.
8 o'clock.
Yes, sir.
Dr. Sukumar?
Yes, sir.
Introduce this.
Yes. Good evening, everyone. On behalf of the Department of Pediatric Surgery, Niloufer Hospital, I welcome you all to this monthly meet for the month of July. Today we have with us Dr. Ravi Ramadwar, sir, as a guest faculty for today's session. Sir is well-known person in the field of pediatric surgery in India. Sir is the President Indian Association of Pediatric Surgeons. Sir is first in India to perform many procedures in minimal access surgery like retroperitoneoscopic pyeloplasty in infants, laparoscopic cortical sparing adrenalectomy, sales lap fundoplication, and so on. Sir has also performed many number of clinical studies and audits in India as well as in UK, which were presented in many national and international meetings and also published in very reputed journals. Sir, we are very much honored to have you among us, sir, and we welcome to this session, sir.
Thank you very much. It's a pleasure to be here with the team from Niloufer.
Sir, our first session for today is a talk on vesicoscopic ureteric reimplantation, how I do it. To give a talk on this topic, we have Dr. VVS Chandrasekharam, sir. Sir, good evening, sir. Dr. VVS Chandrasekharam, sir, is one among the most popular pediatric surgeons in India with special interest in pediatric urology. Sir is a gold medalist from the prestigious All India Institute of Medical Sciences, Delhi, and he has performed the world's largest series of laparoscopic pyeloplasty in India. Sir presented many research papers pertaining to pediatric surgery and pediatric urology in many national and international meetings with more than 30 papers published in international journals. And Sir is author of the well-famous book, Hypospadias Surgery, Science and Art. Sir, we welcome you to this session, sir.
Thank you so
I
much.
hand over the session to you, sir.
Ravi, you'd like to say a few things, say a few words?
Yeah, it's always a pleasure to listen to VVS. I know him since last, how many, 16 years now? First time we met in the ELSA workshop in was it Rainbow Children's Hospital in 2005, I think.
Yes.
And I still have fond memories of that. And we have developed a good friendship since then. And he's been very, very active in minimal access surgery as well as other aspects of IAPS. And there is always something to learn from him. So I'm looking forward to your presentation. Over to you, VVS.
Thank you, Ravi, and thank you, Sukumar. First of all, my heartfelt thanks to Dr. Narendra Kumar, Professor and Head of the Department of Pediatric Surgery in Niloufer Hospital, who has given me this opportunity to speak on this topic, which is close to my heart for various reasons. I'm also honored and humbled by the presence of a very senior pediatric urologist, my very good friend, Dr. Abram Cherian, and my senior at AIMS, Dr. Anupam Lal. So I would, vesicoscopic reimplantation has interested a lot of pediatric surgeons and pediatric urologists across the world, but somehow the number of surgeons doing this operation is not very great across the world. The reason might be that it's a little difficult technique to learn, requires advanced endoscopic surgical skills, and essentially requires a lot of patience to learn it and then execute it. So I would basically, we all know the goals of VUR management. Now, there are many surgical options for VUR: endoscopic injection, minimally invasive anti-reflux surgery, of which there is lever, Rallor, and then the topic of interest today is transvesicoscopic ureteral reimplantation, or TVUR. Now, there are many ways to skin a cat. We will restrict ourselves to TVUR. What I'm going to do is, I'm not going into the indications of anti-reflux procedures or the indications to stop reflux in a child, the surgical indications and all. But I'm going to briefly cover the advantages or otherwise of TVUR when compared to lever and Rallor. Again, we had done a couple of meta-analysis on this topic, so I'll just briefly present the results of the meta-analysis, and then I would straight away go ahead as to why I do TVUR and how I do it. Now, why vesicoscopic reimplantation? Basically, we want to minimize tissue trauma when we are doing surgery. Vesicoscopic reimplantation mimics open Cohen reimplantation. Cohen is probably one of the commonest operations for vesicular reflux that is performed across the world, open Cohen reimplantation. Now, it has been shown that vesicoscopic reimplant significantly reduces morbidity compared to open surgery because of the avoidance of the wide anterior cystotomy, the avoidance of forceful bladder retraction and gauze contact of the bladder mucosa. It has been shown to cause reduced pain and reduced analgesic requirements. And in our own personal experience, it causes reduced bladder spasms, significantly reduced postoperative hematuria, and significantly reduced postoperative bladder catheterization time in our own hands. Now, this is briefly vesicoscopic reimplantation versus lever and Rallor. Again, these basically the results of our own meta-analysis, which we are presenting here. Now, we know this is a Cohen technique, and these are by Lich-Gregoire technique. In our meta-analysis, we found that TVUR was preferred for bilateral cases, whereas lever was mostly preferred for unilateral cases. Rallor had a significant number of bilateral cases in the series. Again, TVUR was preferred for higher grades of VUR, whereas lever was mostly preferred for lower grades or grade 2 to 4 VUR. TVUR, longer tunnels can be made. There is no risk of neurogenic damage. Most problems are basically port-related problems in TVUR, whereas there is a potential risk of neurogenic damage in bilateral cases, both in Rallor and in lever. And there is a higher postoperative urinary retention risk in both these procedures, both being extravesical dissection of the ureter. The success of TVUR and lever were almost identical to open reimplantations, about 94% and 96-97%, whereas Ralur had a lower success, a longer operative time than lever, and used larger ports with an increased cost. So basically, this is one of the meta-analysis we published, and this is another meta-analysis comparing these three techniques. So my personal preference, I started off with lever laparoscopic extravesical reimplantation about 15 years ago. I used to use it mostly for grade 3 to 4 unilateral VUR, where there was not much dilatation of the ureters. But I was not comfortable with lever for bilateral cases for obvious reasons of risk of neurogenic damage to the bladder, and in grade 5 UR with significantly dilated ureters, because I was not very comfortable making those long tunnels, extravesically. And then what happened was, as I started gaining experience with endoscopic injection techniques, most unilateral grade 3 to 4 reflux were undergoing endoscopic injection. So lever was being used less and less by me. Most of my patients who went for surgical correction of VUR were high grade VURs and mostly bilateral VURs with associated issues like Hutch diverticulum or something like that. So since about 10 years ago, I switched to TVUR, vesicoscopic reimplantation, which I thought I could fix any grade of VUR, unilateral or bilateral, simplex or duplex systems, with or without a diverticulum, including megaureters which might require tapering. This is a short video of my extravesical reimplant. I don't need to show it here. It's a standard technique. So what are the technical aspects of, that's the main topic of today. What are the technical aspects of vesicoscopic reimplantation? The most important steps, I think, are patient and surgeon positioning, port positioning, port insertion. This is probably the most important, part of this whole, all these steps. And then the ureteric dissection reimplantation are all very similar to the open Cohen reimplant, and port closure is actually very simple. Now, I have to here mention that there are many ways to position the ports and to place the ports into the bladder. The first step is to fix the bladder to the abdominal wall. There are many ways to do it. Again, the technique that helped me actually start doing this operation more frequently was that described by Dr. Mohan Abraham from Kochi. I'll describe it as I go. We made some modifications to the technique ourselves, but the basic idea of the technique is from Dr. Mohan Abraham. I will be ever indebted to him for teaching me this technique. So this is the position of the child. The child is to the end of the table, and it may be called the French position, I think. The legs are held, are spread apart. The surgeon, I usually stand to the left, on the left side of the child. My assistant stands on the opposite side and holds the camera, and the nurse stands on either side as per convenience. This is Professor Valla operating in his unit, where in small babies, he prefers to stand at the head end of the child. But I've tried this, but I was not very comfortable. This is the position where I'm most comfortable, and I stick to this position in almost all my operations. Now, port positions. The positioning of the port is the most important aspect of positioning of the ports, especially the lateral ports in the vesicoscopic reimplantation, is that the lateral ports have to be in line with the trigone, because you're going to make a transverse tunnel in the trigone. We will see as we go. So if the lateral ports are placed higher, then they come at an angle into the bladder, and it's very difficult to make the transverse, cross trigonal tunnels. So that is the importance. Now, normally I always encourage my juniors and those who want to learn this to draw two lines. One is a line joining the umbilicus and the base of the penis, or the base of the clitoris in females, and there is another transverse line which joins both the anterior superior leg spines. Now, my telescopic port is in the midline. It is somewhere between the junction of these two lines and the umbilicus, somewhere in between. That is the port. That's a 5 mm, usually 5 mm 30-degree telescope is inserted into the port. And these two lateral ports are almost in line with the anterosuperior spine joining line in the mid-clavicular line, basically. But the small thing to remember is in smaller children, if I'm doing it in a 1 year or 1.5-year-old child, which we do it, these ports go slightly higher because the bladder is an abdominal organ in these small children. Whereas in older children, say 4 years, 5 years or older, these ports go slightly lower than this transverse line because the bladder descends into the pelvis, and that is the reason why you put these ports slightly lower in the older children. Now quickly, Dr. Mohan Abraham's technique involves putting a curved urethral dilator into the urethra. Now, so once we have marked all 3 port positions, now the dilator tents up the bladder and the abdominal wall at the site of the marking of the port position. So we incise the skin, and it's very important to excise the little bit of blob of subcutaneous fat so that you can actually see the structures underneath, and you can incise the layers of the abdominal wall under vision. Otherwise, this fat blob is actually going to cause a lot of trouble for the vision through the small incision. Generally, we do not even place even small retractors in this incision. The assistant would depress the abdominal wall like this, with 2 fingers, and then we would incise layer by layer, and the bladder would actually pop up into the wound. You can see here clearly the dilator and the bladder there. Once you incise the skin, you excise the little bit of fat, then the scarpa's fascia, then little more fat, and then you are on the sheath. Once you incise the sheath, you are basically, the bladder pops up. Before this, the bladder is usually filled up to the umbilicus with saline before you start this procedure. But one must be very careful not to overfill the bladder and make the bladder tense, because the bladder wall becomes tense. Then you cannot tent the bladder into the wound. So a tense bladder will be very stiff. Your dilator cannot push it, and it's very difficult to reach the bladder and open the bladder. So the bladder should be filled up to the umbilicus, but it should be lax. It should not be very tense. Now the next step, we take, usually I use a 3-0 Vicryl suture here. I fix the bladder that has been exposed in the wound, either on one side or both sides, to the skin. The full thickness bladder wall to the skin with 1 or 2 stitches. And then the bladder is actually opened, with a blade or a scissors, and you can actually see the dilator through the opening in the bladder, and you can see my 4, mosquito forceps are holding the 4 sides of the bladder. And then the modification which we have done to Dr. Abraham's technique, Dr. Mohan Abraham's technique, is we actually started maturing the bladder at all the 3 places. I mean, same procedure is followed for port insertion at all the 3 places, all the 3 port sites. So we started fixing the mucosa of the bladder to the skin at 3 or 4 places at all the 3 port sites. Basically, this basically started helping us in a big way, because now even if the port slips out during the surgery, it's very easy to reinsert the port. Secondly, the closure of these ports, the closure of the bladder at the port sites, the holes in the bladder becomes very easy at the end of the surgery. We can securely close all the 3 bladder holes so that the urethral catheter or the post-operative bladder drainage can be actually minimized to just a couple of days. So once we do this, then the dilator is pushed out of the wound, and the port is railroaded over the dilator into the bladder, and then the port itself is secured with a couple of sutures with the help of this cuff. And I published this paper on using a Foley catheter cuff over the trocars to secure them. So that is how it is secured. You can use a glove finger or a glove also for this purpose. Now, once we have secured the ports, we've entered the bladder, we maintain my standard pressures are 8 millimeter and flow 1 to 2 liters per minute. And now there are many ways to, the commonest technique followed by most other surgeons is they would put a feeding tube into the ureter, which has to be mobilized, and then a stitch is taken from through the bladder mucosa at the ureteric orifice, and then the feeding tube is fixed to that stitch, and then the feeding tube is cut a few centimeters from the ureteric orifice, so it's very easy to manipulate it. But I have heard a few complications of the stitch cutting through and the feeding tube actually going into the ureter, requiring ureteroscopy to retrieve it. It's very difficult to do ureteroscopy on table in these children. So what I do is I just put, we will see in the videos, I just put the feeding tube or the ureteric catheter directly through the urethra into the ureter. I don't cut the tube, nor I actually take a stitch to fix it to the ureter. It's very easy to manipulate the ureter by holding the ureter itself. And we use bowel grasping forceps for this purpose. And so basically, the presence of the feeding tube, either one or two feeding tubes in the urethra, it also prevents gas leak through the urethra, and it avoids the risk of proximal migration of feeding tube, because part of the feeding tube is actually lying outside the patient's body coming out of the urethra. So then the ureter is disconnected from the bladder, just like open Cohen reimplantation, and mobilized similar to open surgery. The most important points, couple of points here. We obviously use a monopolar cautery hook to do this dissection, and cautery should not be applied directly on the ureteric wall. The tissue should be pulled away from the ureter and then applied. Otherwise, the ureteric injury with the cautery can result in ureteric necrosis and then a uretrovesical fistula later. And also care should be taken at this point to prevent the ureter from retracting into the extravesical space. Now the ureter can go back into the extravesical space. I know I've had a couple of my colleagues saying that they have lost the ureter to the extravesical space and they had to actually convert the operation. So if you have that fear, you can actually put a 40 or a 50 suture into the bladder, and then once you start mobilizing the ureter, once the ureter is mobilized a little bit and still attached to the bladder partly, you can just take the stitch through the ureter and keep it there, so that, you know, if the ureter goes back, you can pull the stitch and retrieve the ureter. These are very important, very simple, very small, but very important points. And believe me, they have helped a lot of my colleague surgeons actually successfully perform vesicoscopic reimplantation. Then, of course, the closure of the detrusor defected. Once the ureter is mobilized, the detrusor defected, the hiatus can be closed either before or after placing the ureter in the tunnel. I mean, it can be done either way. And then you make the submucosal tunnel from one side to the other side of the bladder, transtrigonal. Then placing the ureter in the tunnel, and then ureteroneocystostomy. The first stitch usually takes the detrusor also, and the rest are mucosal stitches. And then you close the mucosal defects. And then I used to place a double J stent in every patient, in every ureter, a reimplanted ureter in my initial experience, but then now I use it on a case-by-case basis. We have actually done bilateral vesicoscopic reimplantation without a stent also, just with a bladder catheter. So if you are not comfortable, you can actually place a double J stent and remove it after a few weeks. And we use a Foley bladder catheter in the bladder. We keep it for about 48 hours. Our median time of catheter removal now is about 48 hours. Now, this is the bladder defect. Once the surgery is finished, the bladder defect, you know, the bladder at the site of the bladder incision is held with forceps. The stitches are cut, and the bladder defect on all three port sites is closed with a simple purse string suture. Very securely, you can close under vision. And once you cut the suture, the bladder just drops back into the pelvis, and you can't actually see the bladder after that. And then the muscle sheath is closed with a single stitch, and the skin is usually closed with either a subcutaneous stitch or with some glue. This is how it looks after this operation. So there are some special situations. This is, in ureters that are not very large, but again, which are not which are larger than the 7 millimeter, but not the very large ureters. We can comfortably perform the intracorporeal ureteric tapering with the folding technique, either Kalsinski or Star or whatever folding technique you're comfortable. Here we have used interrupted sutures. You can see this is actually the very large ureter that we have cut off part of it, and then this mega ureter we have tapered. This is the other ureter. We had one obstructed mega ureter here and one refluxing ureter. So we reimplanted both, and the obstructed ureter we are actually tapering with the help of intracorporeal placement of folding sutures in the ureter. So the other situation is a very large primary mega ureter. This ureter was about 2.53 centimeter diameter. This is an IVP. Normally we don't do, but it's very representative here. Now, in this child, we could do a tapering by extracorporeal, because our bladder is very nicely secured to at the port side. You can just enlarge the one port side a little bit on the ipsilateral side, and the ureter has been pulled out of that port side, and we are comfortably doing an extracorporeal excisional tapering of this ureter. Then you push the ureter back into the bladder, replace your port, and you just complete your reimplantation just like in a standard Cohen reimplantation. Then this was a very interesting child. This child had bilateral grade 4-5 reflux. As an infant, he presented with repeated UTIs. Somebody did a vesicostomy on him, which actually worked for a couple of years. Then for some reason, the vesicostomy was closed with the reflux still persisting and not taken care of. Again, the child started having repeated urinary tract infections, but the bladder was quite, fibrosed, and it was a small bladder because of the vesicostomy for a couple of years. So then we put the child on prophylaxis, and then we put the child on oxybutynin for a couple of years. By the time the bladder became better, and then even in this child with a post-vesicostomy and vesicostomy closure, we could successfully do a vesicoscopic reimplantation bilaterally. Then, of course, our post-operative care is very standardized and simple. Oral diet is allowed after 4 hours. We usually give an IV antibiotic till catheter removal. Either IV or simple IV or oral paracetamol is enough to take care of the pain in these children. Then oxybutynin we always give after any bladder surgery. And then a Foley catheter is usually removed after 48 hours in our series, unless there is a specific reason to keep it for longer. If we have placed a stent, we remove it after 3 to 4 weeks. We usually repeat an ultrasound KUB after 1 to 2 months of surgery, and then an MCG or a DRCG 3 to 6 months after the surgery to check for the success of surgery. So we have discussed this earlier. What are the benefits of vesicoscopy over a standard open Cohen reimplantation? This is a child post-operative day 1 after the surgery. This child had bilateral grade 5 VUR, 5-year-old child. We did a bilateral vesicoscopic reimplant, and you can see the clear urine. We did not place any stents in this child, and we removed the catheter after 48 hours and discharged. Now, my personal experience, I'll just sum up quickly. We have done about 195 children, 114 bilateral, so over 300 ureters. I did about 60 ureters in my first 5 years, and in the next 5 years, we ended up doing more than double that. I mean, I don't know why, I just changed my workplace, that's all. Maybe that was the reason. Then the mean age was about 3 years in our series. The smallest child we did was a 3-month-old baby who had a large or a giant bladder diverticulum, causing a bladder outlet obstruction. But believe me, it's extremely difficult to do this procedure in infants. So I would not advise beginners to attempt it. But basically what I want to say is it is doable. If you are persistent, it is doable. I've done one 3 months and one 6 months. These are 2 babies whom we have done under 1 year. But 1 year and above, we have done quite a few children. And most of the children, as I said, were at least 1 year old. There were 22 primary mega ureters in this series. And out of the refluxing ureters, more than 3/4 of the ureters were high grade, grade 4-5 reflux. And 25 ureters had parauretic diverticulae. 7 of them were giant diverticulae, which we excised and then reimplanted the ureter. 15 ureters we reimplanted after previously failed endoscopic injection. Some in my own hands and some referred from elsewhere. And we had 3 duplex systems in this series where we did a common sheath reimplantation. We did a tapering in total 16 ureters. We had a post-operative MCG or DRCG in 133 children, out of which we had 94% success. Now the mean duration of surgery, only vesicoscopy per ureter, was about 40 minutes. This is excluding port placement and closure. approximate time for port insertion and closure in my hands is still about 30 minutes. About 40 minutes is for the time I take for inserting the 3 ports and then closing the ports. Closing is very easy. It's the insertion which still takes about half an hour in my hands. As I said, that is probably the most important step in this operation. So it's better you spend as much time as is necessary to do the port insertion properly. Then we discuss this, and our median hospital stay is about 2 days. We've had our share of complications. There was a large bladder clot presenting in an older child, about 6-year-old boy, bilateral grade 5 reflux. We reimplanted, discharged in 48 hours. He was playing and then he got injury to the lower abdomen. He came with a large bladder clot, went into retention. And then I had to do a cystoscopy and then wash the bladder through the cystoscope. And then luckily we could clear the clot. Otherwise I was prepared to put in another, the suprapubic port again and then go into the bladder, but that was not necessary, luckily. Then we had almost all the UTIs we had post-operatively were in those in whom we had used double J stents. So double J stent can cause infection. We need to be careful. Of course, most of them were non-febrile UTIs, and there was no urine leak or wound infection in our series. Then a few children developed problems mostly unrelated to the operation itself. We had transient hydroureteronephrosis post-operatively in 6 ureters. Again, all these ureters were not stented, but then they were all transient, and none of them had a persistent obstruction requiring any intervention. This is how we maintain our data. So cosmetic results is pretty reasonable after vesicoscopic reimplantation. You can see hardly visible scars in this child. In this child, you can see 1, 2, and 3 scars. And similarly in this child, these lower scars are usually in the skin crease and they do not cause any, you can't see them at all usually. It's just the cranial, the 5 mm port scar, which needs to be carefully closed so that we can avoid a bad scar. Otherwise, this is very acceptable cosmetic result. Now examples, a 1.5-year-old child with gross reflux and bilateral scarring. This is the post-MCUG, post-op MCUG. Then again, another 2-year-old boy with again high-grade reflux. If I remember, we tapered one of these ureters and then he had a good result. This was a child which we demonstrated in the SPU in 2019 in Hyderabad. This child had duplex with reflux into complete duplex left side, reflux into both the moieties. I had done the vesicoscopic reimplantation in the workshop, and this is the post-operative follow-up MCUG. Again, we have excised giant bladder diverticulae in small children. This is a small child with a giant primary. This is the bladder. Actually, the smaller one is the bladder. The larger one is the diverticulum, and there is reflux into the ipsilateral ureter. I think I demonstrated one such operation in a 1-year-old child in Jodhpur, Pesi also. And our results have been good even after these extensive procedures. I just, 2 of the large series of vesicoscopic reimplantation is one from Jeff Walla and one from Rama Jayanti, and it's very comparable results all of us had, although the mean age of our patients was slightly on the lower side when compared to the other 2. This one. So I'll just show a very short video of a standard bilateral vesicoscopic reimplantation. I'll show a few more videos of little more complex operations using vesicoscopy. So this is the standard view. Bilateral grade 4 reflux in this child. The right ureter was obstructed refluxing ureter. There was a dysplastic terminal segment. Now this is how we just mobilize the ureter. It's very standard as per the Cohen reimplantation technique only. And this is how you separate the tissue and then you pull it far away from the ureteric wall, and then you apply cautery very carefully in slow bursts. And you can see that the feeding tube is 2 feeding tubes are coming from the urethra and going into both the ureters. I have not fixed the feeding tube to the ureter with any stitch. So once they are mobilized, Then we make the tunnel. This is how we make the cross trigonal tunnel. And you can see that my port placement is good here. Sometimes I also place ports wrongly and then suffer. But in this case, at least it was a good port placement. So you can see in one of the ureters, we are taking to the opposite hiatus. The other one, we had to make a new opening on the opposite bladder wall. And this is the second tunnel we're creating. The right ureter, you can see the dysplastic terminal segment, which is narrow. You see the feeding tube is now just being pulled out. And then the ureter is pulled through the tunnel. If you're mobilized well, it just comes and sits there. And then that's the first stitch, which is fixing the left ureter in its place. And you can see the beautiful drainage of urine from that ureter, which confirms that we have not twisted the ureter. And the vascularity of the ureter is good. Peristalsis means good vascularity. So we are excising the terminal, narrow dysplastic segment of the other ureter, which is a obstructed refluxing ureter. And then we've already pulled it through the tunnel, and then it is just a standard. So this is a little more complex procedure. A bilateral VUR, it's not seen in this film, but the child had bilateral VUR and scarring. You can see one large diverticulum on the right side and one smaller diverticulum on the opposite side in this MCUG. So this is the cystoscopy prior to the reimplantation. This is again, that's the ureteric orifice, and there is a paraureteric diverticulum. What we do is we invert the diverticulum. You can see the right side had a very large diverticulum. So we invert the diverticulum into the bladder. Now I have done laparoscopic extravesical excision of giant diverticulum in a child, but it's far easier to do it, intravesically. Especially the reimplantation part of it after the excision of the diverticulum is far easier by this vesicoscopic approach than with the extravesical approach. So that diverticulum is being pulled inside the bladder. And then a circumferential incision is made all around the diverticulum. And the diverticulum is excised, and the ureter is mobilized carefully without injuring the ureter, which is actually, in close approximation to the diverticulum itself. This is again a small child. You can see the very small bladder. There is hardly any space in this bladder. So you stay as close to the mucosa of the diverticulum as possible. Because diverticulum is basically mucosa. So you stay as close as possible. And that is the ureter that we are now mobilizing. That's the peritoneum. You can see the peritoneum beautifully. I'm pushing it off. So that's again a standard mobilization. And then we are closing the detrusor defect. You can see at the site of the large diverticulum with 40 Vicryl sutures, we're closing the detrusor defect. Then the other is a smaller diverticulum, which is excised. The ureter is mobilized, and then the reimplantation is done. The interesting thing is, in a small bladder, if you're excising 2 diverticulae from both sides, sometimes there can be a large mucosal defect. So we can actually use the mucosa of the diverticulum itself to to supplement for the bladder mucosa. So we made the tunnel, and then we are pulling the ureter through. The ureter is being secured in its new position. And the mucosa is just closed. So now this is a child, 1-year-old boy. It was a doctor's child who came with a very large diverticulum. He came with obstructive uropathy, bladder outlet obstruction. Now the cystoscopy, actually primary bladder diverticulum it was. The cystoscopy actually showed 2 diverticulae. One was the large diverticulum at the site of the left ureteric orifice. Giant diverticulum, it was bigger than the bladder. There was another small diverticulum just proximal to it, which was not seen on any of the MCUG. So this was the second small diverticulum. That's the large diverticulum at the site of the left ureter. So the ureter was opening into that diverticulum. So basically we excise both the diverticulae. This is a small diverticulum. Excision is very simple, just like straightforward. That's a smaller diverticulum being excised, and the detrusor being closed. Now after that, the excision of this diverticulum, especially in a 1-year-old child's bladder, is a challenge because this diverticulum is very large, giant diverticulum, almost bigger than the bladder. You can see the very small bladder. The anterior bladder wall is almost touching the diverticulum when I'm lifting it up. But then patiently, if you stay close to the mucosa of the diverticulum, then slowly you can dissect the tissues that are holding the diverticulum in the retrovesical space, and then gradually evert the diverticulum, and then you can excise it. Yeah, now the entire diverticulum has been everted into the bladder. So they are the last fibers holding the diverticulum, which we are excising. And that is the ureter. The ureter is being mobilized. And then we are repairing the detrusor defect at the site of the diverticular, at the site of the diverticulum. And then we excised the diverticulum and then reimplanted the ureter. We didn't even place a stent in this child because everything went so well. We didn't even feel the need to place a stent in the ureter. And we actually sent this child home in 24 hours. And then, the father removed the catheter at home the next day. So that is the maturing the ureter at its new so this is another child, vesicoscopic reimplantation after previous endoscopic injection failure. Dextroamer hyaluronic acid was injected. This case, I think we did a live demonstration in a workshop in Kolkata. So this is very tricky because many surgeons have reported that even open reimplantation is very difficult after previous failed endoscopic injection because of severe fibrosis it causes. But somehow I've done about 15 ureters now and I have not really had so much trouble as that has been described, and we have done all these vesicoscopically. You need to identify there is a capsule, actually there's a pseudo capsule which encases the implant. So once you reach that capsule, once you open the capsule, then you can actually see the material is just coming out. So we are removing all the material that has been injected previously, and then this is then I'll now you can see as I see, yeah, that's the capsule. That's the capsule. That's the fibrotic capsule, which is once you cut that, then the ureter can be mobilized very comfortably. Yeah, now the ureter can be mobilized very comfortably. And after this, of course, the reimplantation is pretty standard. Now we close the detrusor defect. We're making a tunnel here. And I think even in this child, we didn't leave a stent. We didn't feel the necessity to leave a stent basically. So this is the tunnel. Yeah, the distal most part of the ureter, which looked slightly fibrosed because of the injection, is excised. And this is another way of putting the ureter. You need not always pull the ureter to the opposite side. If you make an adequate tunnel, you can push the ureter with the help of your, Maryland also. So that is the reimplantation being completed. And the mucosa being closed. Yeah, that's the completed picture. So I'll show the last video. This is a very interesting case. This child was a 2-year-old, 2.5-year-old girl who came with repeated febrile infections. The MCUG had shown grade 4 reflux on the left side. We were wondering that the ureter was probably inserting slightly low into the bladder. The kidney was scarred on the DMSA, so we decided to go ahead with reimplantation. At cystoscopy before the reimplant, we found that the ureter was actually opening exactly at the bladder neck. So we were wondering whether we should do an extravesical reimplant or an intravesical reimplant. If we do an extravesical reimplantation, then we obviously cannot go till the bladder neck. We'll have to cut the ureter somewhere above the bladder neck and leave a defunctional ureter distally. So we decided to go, since the ureter was not opening in the urethra, it was still just inside the bladder at the bladder neck, decided to go by vesicoscopy, and let's see how we did it. So this is the cystoscopy. That's the ureter, the left ureter opening exactly at just inside the bladder neck. So this is the picture of significant inflammation at the site of the ureteric orifice. You can see that's the bladder neck and the ureter is opening just there. That's the ureter. So we carefully, incise the mucosa all along, all around the ureteric orifice, and then keeping close to the ureteric wall, we mobilize the ureter as much as we could into the bladder. That's the ureter again. So this is the ureter which is being mobilized from its attachments. Basically, it doesn't have any intravesical course. It is just coming from outside the bladder and just opening at the bladder neck. Now, then we decided that we have to reroute this ureter through a neo-hiatus to inside the bladder. So then we saw the course of the ureter. This is the course of the ureter you can see outside the bladder. So we decided to incise the posterior bladder wall vertically along this course of this ureter. This is the mucosal incision we are making. And then we incise the detrusor also in the same line of the incision. And as we do this and keep mobilizing the ureter can be pulled upwards, and then it can be, a new hiatus could be created. Again, more bladder incision of the posterior wall in the same line. That's the detrusor being incised. So now you can see that the ureter has been mobilized in such a way that it is actually entering the bladder. So now the ureter has been pulled up to a normal position into the bladder, but now we had to close this defect we had created in the posterior wall. The ureter was just falling at that place, so we fixed the ureter temporarily to the opposite wall, and then we closed the bladder defect in the posterior wall that we had created in 2 layers. The detrusor is being closed here. It's very tricky suturing there at the bladder neck. So that's the detrusor that is being sutured. It's probably the last stitch, the terminal most portion. It was 40 Vicryl we were using. And then the mucosa was also closed from below upwards, reconstructing the posterior bladder wall which we had opened, making sure we won't close the bladder neck completely. So once we achieve this, now we have a ureter that is entering the bladder at the normal position of an entry of a normal ureter. And then all we had to do was a standard cross triangle. This is the last stitch, which again was fixing the ureteric adventitia also. So that's done. The posterior wall is repaired, and then the standard, Cohen's reimplantation was done. We didn't leave a stent in this patient also, but we left the bladder catheter for a few days more than what we normally would do. So that's the ureter being pulled in the tunnel, and it's just matured there. So that completes this operation. So that's the completed picture. So I will stop here, and I think at least in our experience, most of the ureters that require reimplantation, whatever grade of reflux, simplex or duplex, or with diverticulum or tapering or post endoscopic injection, could be comfortably, I wouldn't say comfortably, but successfully managed with vesicoscopic reimplantation. It's technically difficult, but mimics open Cohen reimplantation with reproducible results. And I think open surgery has very limited role for anti-reflux procedures, at least in our hands. I would stop here. Thank you very much. I would be very happy for any comments and questions.
Yeah, thank you, Chandrasekaram, for a wonderful presentation showing a variety of anatomical variations and how to cope with them. As you had asked me to moderate the session, there are a few questions on the chat box. So may I ask those questions? Or
yes, please.
Yeah. So one of the first questions which Dr. Anil Kumar has asked, which I'm sure a lot of people have probably in their mind, is once you have inserted your first port and the bladder gets decompressed while putting the port, how do you insert the secondary ports and how do you manage it?
Yeah, actually, even if the bladder gets partly decompressed after you insert the first port, it need not decompress completely actually. Because if your port is secure and there is no leak, if your valve is secure, then the bladder won't get decompressed completely. It will get partly decompressed, but that actually doesn't matter. It doesn't make any difference. Because you are tenting the bladder wall, even at the lateral ports, you are tenting the bladder wall towards the abdominal wall with the help of a dilator. So it just, in fact, it's much easier to do it in empty bladder actually. There's no resistance, from inside the bladder, so you can push the bladder, as far onto the abdominal wall as you want.
Excellent, good. So I'm sure Dr. Anil Kumar has picked up this tip. The second question was from Dr. Raj Kiran. He has asked, is it possible to have pneumoperitoneum during dissection resulting from leak into the peritoneum during ureteral dissection?
Yes. Yes. I would say pneumoperitoneum is probably more common in smaller children, say 1.5-year-old children, whose, again, the bladder is an intraperitoneal, as an abdominal organ. So where, especially the first port, which is the 5 millimeter telescopic port, that is where you probably might go through the peritoneum. So I've forgot to mention it in my complications. I had pneumoperitoneum in a very few patients, but after we started fixing the bladder at about 3-4 places to the skin, then usually pneumoperitoneum is not a problem because air cannot leak from there into the peritoneum. Now pneumoperitoneum at the site of hiatal dissection itself, I feel it's quite rare. It is probably possible, but you generally don't open the peritoneum there. Whatever tissues come along, we could see in one of the videos, the peritoneum actually being pushed away. So generally we don't open the peritoneum there, we stick to the wall of the ureter and push all other tissues away. So I think it can leak into the retrovesical space, but probably not into the peritoneal cavity from there.
Okay.
What if you suture immediately of mobilization of the ureter, closure of the detrusor, where you dissect immediately after mobilization? If you close it, then it won't cause.
Yeah, true. True.
So
But
that's what
again,
I did. Even I got the same problem. Immediately there was an pneumoperitoneum, so I started doing that immediately, closing the hiatus.
yeah,
So
but I
that
don't know.
problem is
I don't think it's necessary. Initially I too thought so that you have to close the detrusor immediately because then air might leak out. But it really didn't cause much problem to me, even if I delayed the detrusor closure. In some cases. So I think air leak, if it occurs into the peritoneal cavity, at least in my experience, it is mostly from the site of the first stroke.
No, I think that's very well answered. I think the issue can be worse if you are using higher pressures in the bladder. So
yes,
maintaining low pressures and lower flow rates is the key to avoid all these complications.
yes.
Now, another question Dr. Anil Kumar asked is, sir, if ureter gets snapped while dissecting, how to proceed?
I mean, it didn't happen to me, luckily. Snapped in the sense, it slips away or it actually tears.
It tears apart, yeah. I mean, there are situations in open surgery also where people have avulsed the ureter. So
Yes.
how do you cope with that?
I guess if it actually snaps and slips back into the retrovesical space, I think you have to open up. There is no other option.
Yeah. I think the best thing to do would be to prevent that from happening and put a feeding tube in, especially in your initial few cases, so that you know how to handle the ureter in the bladder and not use excessive traction. Probably would avoid this thing. But as you said, if there is a problem, we need to open up.
Dr. Ravi, can I just make a comment, please? Robert here from Bangalore.
Yes, Robert, yeah.
Yes, so when the ureter went retracted back for me also in my first 3 cases, what I've started doing now is what I used to do in open surgery, which is to take a stay as soon as we start the mobilization and leave a long vicarial stay on that. So even if it retracts back, I can still see the suture to be able to pull it back in. Yeah. I'm just using that as a prophylactic measure now, before doing the mobilization.
Robert, VVS has already discussed the options of stay suture, fixing the feeding tube.
I was just commenting on what the question came. Yeah.
So another question that has come from Dr. Sandeep Kishko is there a model to practice before trying out surgery? How long is the mucosal tunnel? So there are 2 questions here.
Sorry?
Is there a model to practice before trying out the surgery? So is there, apart from animal model, I don't know, there is another one.
I don't know if there is a standard animal model for vesicoscopic reimplantation, but in some of the CMAST, I think we have tried it in.
So we do that in CMAST. Abraham, do you have any model with you guys there? You need to unmute yourself.
The model we've worked with is for extravesical, not for not for the Cohen one.
Yeah.
Could I just make a comment and
sure.
I had a couple of questions if you don't mind.
Yeah.
First of all, VVS, excellent presentation. I am sold into your approach.
Thank you.
But I think you made a very, very important point about the time that you took to establish the ports.
Yes.
That is time invested well.
Absolutely.
Because that is all about setting the stage. Like pyeloplasty, if you get everything sorted, set the stage, suturing is pretty much easy. And one of the deterrents, or at least for me, has been the whole ergonomics of doing vesicoscopic approach.
Yes.
And I guess it is a difficult technique to master, but I suppose you have to take that plunge. Like many such operations, in my early career, I never did pyeloplasty under ones. It's only after I met you that you gave me the courage that, actually it is much more easier to do the infant than in much older kids. So well done. And I really admire your series, your experience. I have a question. So you used a 4-0 needle, isn't it?
Vicryl on a 16 mm needle.
Vicryl.
16 mm needle.
16 mm needle. Yeah.
Smaller needles are better.
And going in and out, Was that an issue?
Yeah. In fact, almost all my like pyeloplasty or any surgery, I usually bend the needle a little bit. I make it almost like the ski needle, and then I push it through the 5 mm trocar. I remove the telescope and push it.
The other two ports are 3 millimeters.
3 millimeter, yes.
Okay. So the introduction of the needle is to a certain extent blind, isn't it?
Yes, it's blind. It's blind.
But that's fine. The tunnel, very nicely done. Is done better than open surgery, actually.
Thank you.
Yeah, one of my other questions was this whole aspect of escape of gas in the retrovesical space, but you say it's not an issue.
I never had a major problem with that, at least.
Yeah.
True.
Yeah. Even when you're excising the diverticulum, it's a potential space that the air can leak out.
Yes.
I need to come and spend some time with you.
You're most welcome, Abraham. I mean, I would be most glad.
I'll be very glad to learn from you.
Great. Thank you so much.
Thank you.
You've been always, very encouraging. Thank you. Anupam was wanting to speak.
There are quite a few questions also. Yes. Yeah, Anupam, please go ahead.
Hi. Excellent presentation, VVS, and I think I had no doubt that you would go to these heights when you were working together. As what Abraham said, I think it's a very time well invested by fixing the bladder. But what do you do when you are faced with someone who is obese and an older child? It's quite difficult to get the bladder all the way up in there. Is there other technique that you do?
It's very difficult. Luckily, we don't have those kind of patients much in India because our age is... I have done a 14-year-old child though. It is really difficult. We make slightly larger incisions and use very small retractors to reach there. And in that big abdomen, those incisions are actually pretty small.
Yeah. I mean, they can be quite difficult. I was struggling with a 13-year-old, 90 kilos child. So it was really kind of difficult. But yeah, I mean, I don't know how much do you see we don't tend to see that many indications to do open reimplantation or reimplantation in children, apart from like a VUJ obstruction. And for that extravesical reimplantation, that's what we've been doing. So I haven't personally done any vesicoscopic, but done a lot of laparoscopic reimplants for megaureters, obstructive megaureters.
I think we are seeing a little different patient profile. It's not uncommon for us to see young children who have, they may have moderate grade of reflux or high grade reflux, but very significant kidney damage. And somehow, some of them really fail conservative management. Again, I have seen kids who have bilateral grade 5 reflux, who have normal kidneys, and I keep waiting for one urinary tract infection to reimplant them, and they don't have it.
Yeah, I mean, very, very true. Yeah.
So I think both sides are both are possible.
Thanks very much.
Thank you, Anupam.
Thanks, Anupam. So the next comment is by Robert. Incidentally, with practice, the handling and suturing and moving around is much easier than a laparoscopy and vesicoscopy. We have not mentioned that. As space is limited and everything stays in vision, so it's probably the better technique than laparoscopy, which I think we all agree. Sandeep Kishku has asked another question. What happens if the mucosa cuts through while making the submucosal tunnel?
We put the ureter there and suture the mucosa over the ureter. You can mobilize the mucosal flap on both sides and then suture it. In fact, even if you leave a mucosal defect, nothing happens. It just, I think, fills up in a few days. The urethrium just grows back.
True. So the same thing you would do in open surgery, you would do in vesicoscopic surgery. I don't think the procedure changes.
Yes.
So Shilpa has asked a question that any precautions, tips to save the vas during dissection? Particularly, I think with your giant bladder diverticulums, paraaortic diverticulums, how do you identify vas there and how do you protect them? And samanya vesicles also.
I mean, I think it's like the recurrent laryngeal nerve in the neck. We don't look for it. So you try to stay away from it. I mean, you basically know where it would come, and then you stay away from it, and then stay very close to the ureteric wall. Basically, you push everything away. In case of diverticulum, stay very close to the mucosa. Diverticulum is just the mucosa. So just very close to the mucosa, pushing all the tissues, away. I mean, that's.
Nazir Al-Nazi has asked, thanks for such an interesting approach. Few questions. Is it applicable to VUJO? And if
Yes.
not, why? So I think the answer is yes. Second thing is, in cases of persistent VUR post-vesicoscopic reimplant, is vesicoscopic reimplant applicable for redo surgery?
I personally have not done a vesicoscopic reimplant for previous failed reimplant, either mine or referred from elsewhere. I think it's possible, but I have not done it. I don't have any experience.
Okay, great. His third question is, any certain indications for placing ureteric stent?
Yeah. The way I look at it is, if the child has a solitary functioning kidney, that ureter you're reimplanting, I would stent it. Second, in bilateral reimplantations, I would tend to stent at least one ureter, mostly the better functioning. I would tend to stent at least one ureter, mostly the better functioning ureter, because I want to avoid, edema and compression and anuria kind of things in the immediate post-operative period. But we have done bilateral without stent. But that is my take. And any tapering, I would stent that ureter. That's probably my indications for stenting.
Yeah. One interesting question by Bala is concerns of irritant effect of carbon dioxide on bladder.
Bala, this has been studied, I think, on the bladder. It has been studied on the kidneys also, actually. The irritant effect has been studied on the kidney because it can go up the ureter, into the kidneys, and it has been it's not been really shown to be harmful.
Yeah, I think as long as you use low pressures, you should be fine. If you're using high pressure, maybe it can cause some damage just because of pressure itself.
Yes.
I think that probably completes most of the questions and discussions. There's one more which has come up. When do you decide regarding tapering for VUJO and VUR? Is the decision same for both?
Yeah, basically, I think it all depends on the size of the bladder and the size of the ureter. Even in a dilated ureter, even in a 1 centimeter ureter, if you can make a 4 centimeter tunnel on the post, it's a large bladder, you can make a 4 centimeter tunnel, you need not taper it. The other thing in VUJ obstruction, I've actually mentioned it in some workshops also. In some cases of VUJ obstruction, it is the distalmost part of the ureter just proximal to the obstructed segment that is bulbous. So if you mobilize the ureter little excessively into the bladder, you can comfortably excise that bulbous segment, and the rest of the ureter can be easily reimplanted without tapering. So the aim is to avoid tapering whenever possible, but you can do it by vesicoscopy even if it is necessary.
So it's like Hirschsprung, you resect the dilated segment and bring down the near normal segment. Yeah.
Yes.
One question which Bala has also asked is there a need for long-term oxybutynin in patients who have undergone these procedures? I think you already mentioned it's not.
I don't think. If I have put a stent, then I give oxybutynin 0.1 milligram per kg per dose, 2 doses, till I remove the stent, because stent sometimes causes bladder spasms and a lot of irritation to these children. But I forgot to mention there are about 3 patients in this who had post-urethral valves, the secondary VUR, persistent VUR, bilateral after post-urethral valve ablation, and then normalizing of the bladder functions. In those children, maybe it is actually required to continue the oxybutynin for 3 to 6 months after the reimplantation, but not in a primary VUR.
Okay, great. So is that your
one question?
Yeah, Anupam, go ahead.
Just one. What do you mean by low pressure? What is your low pressures? How much is the pressure?
The pneumovesicum.
Yeah.
I usually maintain it 8 millimeters is my pressure.
8 millimeters.
I usually don't, even in a big bladder, 8 millimeters is good enough. In small children, you can come down to even 6.
Okay. And another thing was you do Cohen's. So if post Cohen's, if you have to do any instrumentation through the ureter,
I know
that's going to be a nightmare. So
luckily, I never
do you prefer Cohen's?
Yeah. I never had to do an instrumentation post Cohen's, but yeah, as you rightly say, but I think there are techniques now to instrument them.
Yeah, I mean, you have to go to suprapubic and then,
yes.
Yeah, I mean, this is a common concern for all adult urologists that pediatric surgeons and pediatric urologists do Cohen's, and what do we do with them afterwards?
With the stones.
Yeah, with the stone disease, particularly in India, in particular sections where the incidence of stone disease is very high.
Very high.
That could be a problem. So I agree, it's a very important question to be kept in mind. I think that completes all the questions, VVS. It's been an excellent presentation as always. Wonderful technical exposition as well as discussion and the reasoning behind every single aspect of whatever technical tips you have given.
Thank you.
I'm sure everybody has learned a lot, and we all will continue to have learning sessions with you in future also.
Thank you so much. Thank you.
Thank you. So I just wanted to mention one point. In few of the videos, this is for all laparoscopic surgeons. In few of the videos, whenever you are using diathermy, there was disturbance on the screen with horizontal or oblique lines.
Correct.
So that means that the diathermy earthing is not proper, your return plate is not proper, and that current is actually flowing back through the telescope to your camera, and it may burn down your camera at some stage. So whenever you see this, or you see a white flash on your vision, whenever you are using diathermy, be very careful to prevent damage to expensive cameras. Check your diathermy connections properly. And it's a very, very useful tip for all laparoscopic surgeons.
Yes. Thank you, Ravi.
Can we move on to the next session?
Yes, sir. So we'll move on to the next session. Yes, sir. We'll move on to the next session, sir. It is a session on general. I invite Dr. Satyanarayana, sir, to present the general.
Good evening, my teachers, seniors, and my colleagues. Today I'm here to present the general watch for July. So the topic of interest today is the congenital lung malformations management by thoracoscopy versus thoracotomy. So we are discussing 4 articles in this. So why are we discussing this? As the incidence of antenatally diagnosed congenital lung malformations is rising due to the improvements in the prenatal sonography, it is stated that in 1 in 3,000 were present. So children with congenital lung malformation have potential to develop complications such as recurrent pneumonia, respiratory compromise, pneumo or hemothoracis, and even malignancy. The mainstay of management remains surgical resection by thoracoscopy or thoracoscopic approach. So by waiting for 3 to 6 months post detection of the pulmonary malformations, we have seen that there is increased risk of infection leading to adhesions, making the surgery difficult, may lead to increased blood loss, hence increasing morbidity and length of the hospital stay. So there are even case reports of pleuropulmonary blastoma have been seen. So in general, minimally invasive surgery has made a huge influence in patients' morbidity and length of the hospital stay. Thoracoscopic surgery showed to significantly decrease the long-term and short-term morbidity. So we want to examine the long-term and short-term outcomes in children who underwent surgery thoracoscopically and thoracotomy. So the indications for surgery included CPAMs at congenital pulmonary airway malformation, which are the most common ones, and intralobar, extralobar sequestrations, hybrid types, and congenital lobar emphysema, and pleuropulmonary blastoma and severe bronchiectasis. So this is the first article we want to discuss. That is, does thoracoscopy have advantage over open surgery for asymptomatic congenital lung formations? An analysis of 1626 resections. This is a systematic review that has been conducted with sample size of 1626, wherein which 904 were operated thoracoscopically with a conversion rate of 10%. So 722 were standard thoracotomy was done. So number of studies included were 36 in this, in which the duration of the surgery showed that there is 37 minutes longer than the open procedure on an average. The length of the hospital stay is decreased by 1.4 days less than the open procedure. So this we have seen that the average age of resection for thoracoscopy is 17 months and 13 months for the thoracotomy. The complications significantly less in children who underwent thoracoscopic resection, and the complication rate, the overall complication rate favors thoracoscopic excision over thoracotomy for asymptomatic antenatally diagnosed congenital lung formations. The complications that were looked into are like early and late complications such as tracheal injury, prolonged air leak, pneumothorax, resurgery, bleeding, wound infection, recurrence, inadequate resection, chest wall deformities, scoliosis, and even death and malignancy. Death was not reported in any of the cases. A reduced total complication rate favors thoracoscopic excision over thoracotomy for asymptomatic antenatally diagnosed congenital lung formations. So thoracoscopic resection is therefore not associated with more risk than open surgery. So in support to our first article, there are other articles which we want to discuss. There's a long-term pulmonary function after lobectomy for congenital pulmonary airway malformation. A thoracoscopic approach really better than open. This is a study from Hong Kong, and in this journal we compare the long-term pulmonary functions. The duration of the study is from 2000 to 2008. The surgeries performed during this time period have been taken into consideration. The methods are like the pulmonary function tests were done 7 years post-surgery. Sample size is 24 with 12 in each group. The results, the thoracoscopic group showed better performance in the forced vital capacity is good, and forced expiratory reserve volume in the first second is very good. And the alveolar volume diffusion of the carbon dioxide was also good. But the ratio of FE1 to FEC ratio and lung capacity residual volume showed no statistical difference. Now, hence, it was concluded that the poor pulmonary function test resulted in open lobectomy children may be due to impaired respiratory musculature. So, in comparison to the advantages of thoracoscopy, there is a comparative study of thoracoscopy versus thoracotomy on musculoskeletal outcomes in children. This is also done by the same group from Hong Kong, and it has been postulated previously that VATS is better due to the shorter hospital stay, reduced post-operative complication, better long-term pulmonary outcome. In this study, we are comparing the long-term outcomes of both surgical techniques and musculoskeletal outcomes in this group. The sample size was 35 with mean follow-up of 10.42 years from 5.48 to 17 years. The screening of the musculoskeletal defects that were considered was the elevation of the shoulder, asymmetry of the nipple, brush of the pectoral muscle maldevelopment, winging of scapula, scoliosis, shoulder range movements and power, measurement of bilateral chest wall. So the results have shown that the prevalence of winging scapula is significantly lower in patients who underwent VATS than thoracotomy, by 13% versus 58%, which is a very significant number. So there is also a smaller reduction in operated side chest wall vertical distance in VATS patients, no significant difference in other deformities. So it has been concluded that thoracoscopy decreased the incidence of winging scapula. So this is the fourth article wherein which we have, it's a European multi-center survey, the thoracoscopic management of pediatric patients with congenital lung malformations. The European multi-institutional experience about the thoracoscopic management of children with congenital lung malformation has been considered. The sample size of 102, 53 boys and 49 girls. Retrospective study of 5 European pediatric surgery units has been taken into this. They have done 18 upper, 20 middle, and 64 lower lobe resections. They used a 3 mm sealing device and 5 mm stapler. Later in 48 cases, which decreased the time by to very shorter duration compared to the suturing they have used prior. The median hospital stay for these patients was around 3.7 days with the least of 2 days. A reoperation was done in 1 case of residual pleuropulmonary blastoma. To conclude in this, there is excellent cosmetic outcome in experienced hands, and strongly recommend surgery in patients with congenital lung malformations by first year of life to prevent the infection rate, and due to which the surgery would be better as there were no adhesions, and we can go for a better resection, and even the blood loss would be minimized. So early surgery reduces the risk of infection and make procedure technically easier despite small patient size. Thank you.
Say, Dr. Satsrana.
Sir.
Anywhere they have mentioned the measures to reduce the volume of the lesion. Certain conditions like congenital lobar emphysema,
yes, sir.
cystic adenomatoid malformation.
Yes.
So they occupy most of the space in the left hemithorax.
Yes.
And we don't have space to enter it. So they have mentioned any measures to reduce this volume of the lesion before we do the lobectomy. Have they encountered any of the problems like that in any of the 4 articles?
No, sir, it has not been mentioned, sir.
Yeah, Dr. Narendra, this is more
experience of Dr. Ravi Ramadwar.
Yeah, I'm just coming to that.
You can stop sharing.
So to answer your question, all those 4 papers which you have discussed today, the articles you have discussed, these are all large series, multi-center studies looking at various experiences and meta-analysis. So they are not going to discuss the technical details. So these are not the correct paper to look for technical details. But on the whole, if you want to reduce the size of the lesion, particularly for very large lesion, there are multiple options. One, if you feel that there is a large feeding vessel in a bulky tumor like a solid lesion in the lung, you can embolize the lesion, and which is known to reduce the size of the lesion. Then this is a pre-operative thing. Secondly, if at the time of surgery, when you insert the trocars inside, you can actually decrease the size of the lesion by gradually coagulating the various alveoli or cystic component of the lesion by either harmonic or a ligation or a bipolar if you have bipolar. So that way you can create space, release adhesions, and gradually go on shrinking the size of the lesion, and you will be able to do resection much more comfortably in almost all patients. Very rarely you will struggle. You will struggle in patients who have multilobar disease on the same side of the lung. And that is where the difficulty can come, and you may have to convert into open surgery.
Ravi, about your own experience with thoracoscopic lobectomy, a few words.
Yeah, so before coming to that, I think one of the important point, sorry, I forgot the name of the guy who presented the journal was.
Dr. Satya.
Dr.
Satyanarayana.
Yeah, Dr. Satyanarayana, one of the important point which you missed out in one of the meta-analysis that is mentioned, or a multi-center study that is mentioned, that there are 4 factors which are very important to perform the procedure successfully without any conversions. Do you remember them? Can you enumerate them? Is it possible? Because that is a very, very important take-home message for people to get on with thoracoscopic lobectomies in younger population.
The early intervention is one, sir.
Yeah, early intervention is one. One more important thing. First and foremost thing. The first most important point is a properly performed CT scan.
CT scan, yes.
And understanding the extent of the disease, the anatomy of the disease process, accessory blood supply, or involvement of other multiple lobes. So this is something which has to be done. And in fact, in my own practice, what I tend to do is I would sit down with the radiologist and reconstruct the entire thoracic anatomy. They have fabulous software where they can give you transverse section, longitudinal sections. They can cut away portions of the areas. They can rotate in 360 degrees to show you exact anatomy of the chest and show you what exactly is going on at the hilum or in the peripheries. And that makes things very, very comfortable. So I think spending time understanding the anatomy and the disease process makes surgery much more simpler. So that is a very, very important point. Second thing they had mentioned is experience of the surgeon.
Yes, sir.
In most of the multi-center studies which they have mentioned, particularly the European one, the experience of the surgeon was vitally important to make sure that there are no conversion, the surgery is performed safely. So this is thoracoscopic lobectomy is not something which you should start with. You need to generate adequate experience in minimal access surgery before you go on to the thoracoscopic lobectomies. And that's a very important key factor for everybody to understand. Third important factor which you have mentioned is use of ligature or staplers of a smaller size. Unfortunately, just right equipment which the study mentioned is not available in India. So we do have 3mm bipolar instruments which you can use in the same way, or you can use various locally manufactured equipment in a similar fashion. But staplers is something which is not available, so you can actually suture ligate the bronchus, or you can even use the Ligia clips, or you can use the hemlock clips on the bronchus. So these are the options to reduce the operative time. But the important thing is the operative experience of the surgeon or a senior surgeon to hold your hand to take you through the entire process.
Yes.
I think these are the few important points which we need to discuss whenever we go through the large series, because that's a very important conclusion. Now, in my own experience, I haven't faced a situation where we had a problem of creating space. So to answer Dr. Narendra's question, I generally use a ligature, which is available in most of the hospitals which I operate, and I operate in 6 different hospitals in the city. And these are all expensive hospitals, so they have all the expensive gadgets available. So we can use the ligature or a harmonic if required. So that helped me in reducing the size of the lesion. Many times the anesthetist is uncomfortable giving us a single lung ventilation, or they attempt a single lung ventilation and we still have some CO2 coming out for whatever reason, maybe change of position affecting their position of the tube in a single bronchus. Except in older children where they can put in a double lumen tube, we do face the problem of the lung becoming inflated at the time of surgery, which sometimes actually helps. In most of my patients, I have not seen a very well-formed interlobar fissures. They are incomplete in almost all my patients. I think maybe 1 or 2 patients I must have seen properly formed all the fissures which you would expect in most of the videos in Western population. So we have certain anatomical variations. The other important thing to remember that many of our patients would have had infections which are not noticed or reported by the parents or by the pediatricians, because many of these patients with even with mildest of respiratory infection or a febrile episode, they are given antibiotics. And a lot of time this is actually infection into that cystic malformation or the CPAM, and that induces significant fibrosis. It induces significant inflammatory response in surrounding tissues. You also have lots of lymph nodes at the hilum, which is something which you don't see in Western population, because most of the videos whichever I have seen in being presented in Western population, there's hardly any lymph nodal enlargement. And I think almost 60 to 70% of patients which I have operated would have fairly sizable lymph nodes at the hilum. So that is something which adds to the difficulty. I think these are the few points which I would like to mention. And as I said, you need to be well experienced before you get on with the with thoracoscopic lobectomies. Another important thing is our pediatricians are reluctant to send patients for thoracoscopic or open resection because they say that these lesions disappear over a period of time. I don't know how they get this idea, but these are the patients who will come back later with lung abscesses, with bronchiectasis, and there is no long-term follow-up of all these antenatally diagnosed malformations in a proper way to say that they completely disappear. As we know from the Western literature that 30% of CPAMs which are diagnosed antenatally will become symptomatic. So 70% of these surgeries are performed in asymptomatic patients, but I think they prevent lots of complication, which is particularly important in a country like ours where resources are limited and infections are in huge numbers of all kinds. So this is something which we need to convince our neonatologists and pediatricians to send the patients early and not to wait for infections to occur, because that makes the surgery much more difficult. VBS, you want to add anything?
Yeah, Anupam wants to say something.
Thank you, Dr. Ravi.
Anupam?
Hello?
Anupam,
yeah.
Go ahead.
I think a very important point that Ravi made was about the road mapping. For the tumors, now what we do tend to do is looking at all the CT scans and everything, we would make a 3D model, and that gives an excellent roadmap. So you plan the surgery way before you actually do the surgery, and that makes it much, much easier.
Yeah. Ravi, we have tried thoracoscopic lobectomy in about 5 patients. 1 I had converted. The 4 we could complete successfully. 2 of them were infants actually. Mm-hmm. Now, as you rightly said, if we have the stapler, 5 mm stapler, the life would be easier. But I think we will have to manage without that, till it actually becomes available. In an 8-year-old girl with the right load lobe CPAM. Exactly what you were saying. The child was going through multiple infections. The pediatric pulmonologist would refer the patient to us for surgery. They would come, get counseled, and then go away. And then after a year or two, one more infection, they would come back. So finally, at 8 years of age, we did the lobectomy. In that, we tried actually the adult staplers. So we thought at an 8-year-old child, we might be able to get away with stapler. But even in that child, the 12 millimeter stapler was very difficult to fire because, the length of the stapler would actually pierce out of the chest wall. It would not, open comfortably inside the chest. So I think we will have to handle these cases with the available equipments of, clips and sutures and, but as you rightly said, I think the most important factors are a thorough anatomy. And in fact, even if the CT, I would go to the extent that even if the CT scan doesn't say that there is a aberrant vessel, I would still look for it. I think this is what Steve Rothenberg has always been saying, that the CT scan might not, reveal a vessel sometimes. I mean, we know the quality of the CT scan, but then you should always look for the vessel, especially in lower lobectomy. You should look for the vessel in the inferior pulmonary ligament, because missing that would be a disaster.
Yeah.
So,
in fact, what I tend to do is many patients would come with CT films, or they would have a CD of their CT, which will be generally loaded in our system, and then we analyze it. And many times we find that the CT quality is so poor that you can't really understand what is going on. So then I would repeat a high resolution CT scan to understand what is the exact anatomy, to plan my surgery in such a way that it is very safe and easy to complete. And we had done nearly 70 thoracoscopic lobectomies till date, and with variety of combinations. And it's a very safe way of doing it if you know what exactly is the anatomy likely to be. And as we have discussed, I think in the past also, that we don't try to ligate the major branches at the hilum. We go into the lung parenchyma near the hilum so that we can identify individual branches of the artery and possible vein also, so that you prevent catastrophic injury to the vessel, which can retract in the pericardium, and then it might be a serious issue for you. So that is something which we can discuss in some of the technical presentations. Right. Any questions?
Thank you, Dr. Ravi
Ramadwar, to make?
For sharing your knowledge, and also for sharing the very valid points.
Thank you, Dr. Narendra Kumar, for inviting me. And
we thank Dr. Anupam Lal and also Abraham Cherian for joining this session, sir.
Thank you very much. It was an excellent session.
Thank you all. Thank you.
Good night.
Good night, sir. Thank you all. Thank you.